Welcome to the Onvida Health Base Hospital EMS Treatment Guidelines video tutorial series. This is Dr. Franco Castromarin, and you're watching Part 5, Pediatric and OBGYN. This video is intended for any EMS provider who's operating within Yuma County with Onvida Health, formerly known as Yuma Regional Medical Center, as your base hospital and administrative medical direction. Please confirm with your chain of command if you are not sure. The primary objective for this Part 5 video is to go over in detail every page of treatment guidelines in both the pediatric as well as OBGYN sections. The setup is simple. When I'm comparing a new guideline to an older version from the YRMC protocols on the same or similar topic, the new version will always appear on the right of the screen and the old version will be on the left. They will be labeled in the top left corner of every page, new versus old. Having the old material available for comparison will help you build familiarity and comfort with this new content. Along the way, I'll point out important details on each guideline and share some effective teaching pearls. Remember, you will always have access to this training content, and you can come back to review it at any time at your own pace as often as you'd like. I encourage you to have your mobile device out and use it to follow along as you watch these videos. One of the advantages to this rollout is that we are using the same mobile app vendor called Acid Remap to host our guideline document, so much of the app navigation should be familiar to you already. As you may know from using the Acid Remap mobile app, there's a way to make your own notes. Feel free to use this function frequently as you pick up useful teaching pearls from these training videos. To set the stage for discussing the next two pages, let's first look at the old respiratory distress guideline on the left. As you can see, the flow diagram creates three pathways: stridor, wheezing, and respiratory arrest. But you'll notice that for stridor and respiratory arrest, there's really no actionable information other than to treat what you see and provide a pre-arrival notification. With the new guidelines, we want to present a cleaner process. As a reminder, if you encounter any patient of any age with respiratory failure or respiratory arrest, you can use the airway management guideline that we covered in the prior video. For any child with stridor from suspected croup, there will now be a pediatric stridor guideline, which we'll cover next. So for here, let's focus on wheezing. In the center of the old guideline is the wheezing pathway, and this really was intended to apply to any pediatric patient less than age 15. As I'll review shortly, this is not correct to think of all pediatric wheezing as the same disease process and then treat everyone with albuterol and steroids as you typically would with asthma. The more correct way to break things down with wheezing or bronchospasm is to split patients into two groups: children younger than age 2 and everyone else. If you've been watching these training videos in order, you will have already been introduced to the bronchospasm guideline, which is now applicable to everyone from age 2 and beyond, including adults. Please go back and review that video as needed. In that same video, we covered the guideline that addresses pulmonary edema in all age groups as a cause of respiratory distress. This new guideline will be applied to patients younger than age 2 with wheezing and bronchi. Paramedics will notice that there's only one medication listed on this entire page, and that's nebulized epinephrine. Your eyes do not deceive. There is actually no role for albuterol, systemic steroids, magnesium, and certainly not intramuscular epinephrine in the pre-hospital setting for these younger infants with wheezing. Why is that? Because this isn't asthma. These younger infants aren't wheezing from allergic reaction or from reactive airways. Most of the time, it's actually acute bronchiolitis. If you remember, that's a viral infection that causes airway inflammation, excessive mucus secretions, and edema, not smooth muscle constriction. As it turns out, albuterol doesn't fix those other things. As you see in the inclusion criteria, not only is this new guideline about wheezing, it's about all of the respiratory findings related to viral illness: rhonchi, excessive secretions, cough, fever, and generalized respiratory distress that can lead to fatigue. Here in the exclusion criteria, we have included hyperlinks for other conditions that present with respiratory distress like anaphylaxis, croup, as well as drowning and foreign body aspiration. This isn't the guideline for those other conditions. You may have seen I put out an education memo last year explaining why these younger infants with viral wheezing are not treated with albuterol. In that memo, we reviewed that wheezing results from air trying to pass through a narrowed airway. In the case of infants younger than age 2, the most common cause of wheezing is from acute bronchiolitis. And again, that's a viral disease process manifesting with nasal congestion, cough, bilateral crackles, air trapping, and wheezing. Viruses cause mucosal edema and accumulation of inflammatory debris, as well as swelling of the lymphatic architecture in the lower lungs. These are the factors that end up causing narrowing of those lower airways for these patients. Mucus plugging, airway wall edema, and compression from those neighboring structures. Albuterol does not treat those factors. The drug does nothing to displace all that mucus out of the respiratory tract. Remember that albuterol stimulates the beta receptors on airway smooth muscle cells that line the bronchial walls. This stimulation activates a cellular pathway to relax airway smooth muscle and thereby relieving that constriction. That's why it works to treat asthma, which features airway smooth muscle that is totally dysfunctional and prone to excessive contraction and impaired relaxation. Those are not the factors at play in an infant with a viral infection. There are many studies to back up this idea, confirming that albuterol doesn't help kids with bronchiolitis. It doesn't speed up their recovery. It doesn't reduce the need for hospitalization. It doesn't shorten hospital length of stay or improve hypoxia. The American Academy of Pediatrics recommends against the routine use of albuterol or epinephrine for patients with mild to moderate bronchiolitis. There is sometimes a role for nebulized epinephrine for patients with severe bronchiolitis, and that's why we kept that medication in this new guideline. On the other hand, much like albuterol, there really is no role for steroids to treat viral bronchiolitis. So where does that leave us on the new guideline? Well, most of what you need to worry about is captured in the EMT section: suctioning of the nose and mouth and application of supplemental oxygen as needed. Paramedics can step things up with CPAP and nebulized epinephrine as shown down here. Other critical actions include continuous monitoring of end-tidal CO2, transporting all patients who've received inhaled epinephrine, and avoiding placement of an IV or IO unless there is critical need. The idea is to always minimize patient distress and agitation to keep their respiratory demand in check. In summary, the new framework for pediatric respiratory calls is to try to focus first on the primary signs and symptoms: wheezing, stridor, pulmonary edema, respiratory failure, or complete respiratory arrest. Then you match up the situation to the correct guideline page. For wheezing in particular, we break it down by age. Infants less than 2 years old are managed from this guideline, and all others are managed using the bronchospasm guideline. Moving on to the next page, let's now look at the stridor guideline. As you remember, stridor is that high-pitched wheezing that results from narrowing of upper airway structures such as the epiglottis or other parts of the laryngeal inlet or trachea. This could be caused by a foreign body, but this guideline is really intended to manage a patient with another very common viral condition known as croup. Croup causes edema of the epiglottis, resulting in that classic cough that sounds just like a barking seal. The good news is that all of the management on this page exactly matches up with that from the previous page, except that you can repeat epinephrine as needed with unlimited frequency. And also for croup, we should administer dexamethasone. Next up is the guideline for a brief resolved unexplained event, also known as BRUI. You may remember this as ALTI, or apparent life-threatening event. This is an all-new guideline. This clinical entity has a very specific definition, which is summarized here at the top of the page. This term, and thus this whole guideline, will only apply to an infant younger than 12 months who experiences a sudden, brief episode that is considered frightening to the observer and is otherwise unexplained and completely resolved by the time EMS arrives on scene. It will feature some combination of abnormal or absent breathing, including choking, gagging, some type of color change on the skin, usually consisting of cyanosis, or pallor, but not isolated redness of the face or isolated cyanosis of the hands and feet. Usually there will be some significant change in muscle tone, whether the patient becomes limp or rigid, as well as some associated altered level of responsiveness, either increased or decreased. Any child who's over age 12 months has some other obvious explanation for what is going on, such as a primary respiratory problem, seizure, or cardiac arrest, should be treated in accordance with those other conditions and not with the information on this page. Critical actions will include airway support as needed, checking blood glucose, and staying alert for possible child abuse. All infants who have experienced a Bruy type of event must be transported to the hospital, specifically a facility that has pediatric services, so don't take them to any of the freestanding emergency departments. If there is a parent or guardian who wishes to decline transport, you should absolutely call for online medical direction. As was the case with the respiratory guidelines that we just discussed, paramedics should avoid obtaining IV access unless it is necessary so you don't cause further agitation. As with all of our pediatric airway management, please stick to the least invasive approach necessary. The last guideline in this section is neonatal resuscitation. This is intended only for neonates immediately following birth. The way we phrase it here in the inclusion criteria is a neonate who is transitioning from the intrauterine environment to the external environment. In other words, from the womb to the world. We had recently updated the old version of this guideline, so all of this information and basic layout should look pretty familiar. You start with clamping the cord, you continue with stimulation and providing warmth, and then you decide if the infant is stable to be handed directly to the mother for skin-to-skin contact or whether you will need to provide more hands-on management, including airway positioning or suctioning. Here is the hyperlink to the APGAR score in the appendix. As before, we have this warning clarifying that routine suctioning is not recommended, but now we have added a stop sign icon for emphasis. Ongoing management depends on heart rate in that first minute of life. All of this information and the way it is broken down is the same as before. As a quick reminder, if you're using a BVM to provide supplemental oxygen, the flow rate should be set at least at 15 liters per minute in order to deliver 100% FiO2. As far as paramedic information goes, the highlights are sticking with the least invasive airway support method necessary, as well as starting epinephrine at the same time as chest compressions. As far as this glucose treatment information that we had on the old version, we have embedded the hyperlink to the hypoglycemia page up here in the EMT section where you can find all of the dextrose and glucagon orders that you might need. Moving on now to the first of two OBGYN guidelines. This first one is focused on childbirth and its potential emergency complications. This will be a new guideline for you. Here in the EMT section, we include all the steps you should follow to execute a standard vaginal delivery. This very first statement with a caution icon reminds you to always support the infant's head to control the pace of the infant's body as it passes through the vaginal canal. In other words, never release that point of contact, ever. Further along, we have a hyperlink so you can document APGAR scores and this link back to the neonatal resuscitation page in case you need to pivot to that guideline. We have one detail with a stop icon to remind you not to perform suction unless you identify an actual airway obstruction. Next, we summarize all of the critical actions for the various emergencies. These include shoulder dystocia, prolapsed cord, maternal cardiac arrest, breech birth, and postpartum hemorrhage. Most of these rescue maneuvers will fall within a BLS scope of practice except for these additional steps here in order to manage postpartum hemorrhage. I'll encourage you to review each of these details on your own time. For paramedics, as long as it's within 3 hours of delivery, you will now administer TXA to any patient with ongoing postpartum hemorrhage that does not resolve with high-quality fundal massage. Please note that unlike the trauma guideline, where we also feature TXA administration for hemorrhagic shock, For postpartum hemorrhage, the evidence-based recommendation is that you can give another 1 gram repeat dose of TXA if the bleeding continues beyond 30 minutes after the first dose. Closing out the OB section is this guideline that focuses mostly on eclampsia and preeclampsia. The old protocols do have this one page titled Obstetrics, and this is the closest match to the new guideline. In the EMT section, we cover actions such as checking a glucose, monitoring pulse oximetry, patient positioning depending on how many weeks they are pregnant, as well as identifying the circumstances for which placing fingers into the vaginal canal is appropriate. In the paramedic section, we have the parameters that indicate the need to treat with magnesium. This section lists the possible symptoms of preeclampsia, which would feature a blood pressure above 140/90, along with any one or more of these items listed here. Now, eclampsia is the occurrence of seizure, which can actually happen even without elevated blood pressures in a pregnant woman. These syndromes will occur somewhere between 20 weeks gestation all the way out to 6 weeks postpartum. Paramedics should administer 4 grams of magnesium, as we have done in the past, but the timing of the dose is simplified to 20 minutes rather than 10 to 15 minutes. The old version had this list of high-risk elements which interestingly made no mention of elevated blood pressure, nor did it explicitly list the actual features of preeclampsia. Those are significant omissions that we are fixing with this new guideline. Please take time to review preeclampsia and eclampsia, as well as their features, so you can correctly identify and treat these very dangerous conditions. In fact, I found this quick read online that does a really great job explaining this otherwise complex spectrum of disease. That concludes Part 5 of the Onvida Health EMS Guidelines video tutorial series. Thank you for watching.